So the last two examples were kind of about clinical outcomes, but this is where I'll kind of spend most of my time today, which is on variation in clinical practice. And so one area we've been very interested in is looking at the ways that implementation science can help improve antimicrobial use in sepsis. So just kind of from a high level view, this is the variation in time to antimicrobial delivery for veterans hospitalized with sepsis across the VA health system. And so what we see here is that there's fairly pronounced variability, but also that the median time to antibiotics increased over time. So between 2013 and 2008. So this is a space where we think that implementation science could definitely make an impact. Next slide, please. Next slide, please. Thank you. And so just a few quick definitions in terms of implementation science and implementation research. So we define implementation science as the study of methods and strategies to improve the uptake of evidence-based practices into regular use. We think of implementation strategies, which are a key component of implementation work, as the methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. Kind of put in another way, this is the how-to component of how we get from a problem or a gap to a potential solution. Next slide, please. So one important component of implementation research is theoretical frameworks. So we use a lot of different frameworks, but this one in particular has been especially. So what you see here is kind of a graphic representing the VA Quality Enhancement Research Initiative implementation roadmap. And so this is a process framework that walks through different activities and important questions we need to be asking across three phases of implementation, which are pre-implementation, implementation, and sustainability. I won't go into too much detail here, but really the general idea is just that kind of within each of these bins, we have different questions we ask and kind of different activities. I'll spend most of my time for the rest of the talk on this pre-implementation and implementation phase, simply because this is an area where there's been quite a bit of recent interest and research in terms of how we incorporate health equity, which could be helpful and relevant in addressing sepsis disparities. Next slide, please. So I'll spend some time here. I think this is an important component of the query implementation roadmap. So like I just mentioned, within this pre-implementation phase, kind of here we're doing kind of things to plan for implementation. And so what you see here is a stepped approach to getting from a clinical problem or an observed gap to a potential solution, which is the implementation strategy. So starting on the far left, kind of our first step is to assess practice gaps and kind of understand where current practice sits. The graph I showed with variation in antibiotic times would kind of be an example of this. This is where there may be a gap that we can start to address. Kind of two boxes over to the right. So this is where we're going to start thinking through, what potential interventions, solutions, innovations might help address this important gap. Step 4 is a key one as well. So this is where we use theoretical frameworks to identify barriers and facilitators to implementation of the intervention or practice that we just identified. So this is really kind of the bulk of the pre-implementation process, and this is where we really try to understand context. So kind of we're trying to implement something. What is the context that we're working in? And so it's just kind of jumping down to step 6. Here is where we use theory again to design an implementation strategy. And so we want our strategies in general to be linked to the barriers we want to overcome and kind of helping to improve or facilitate implementation within the context that we're working. And so really, I just to summarize there, this is a helpful kind of stepped approach to getting to an implementation strategy. Next slide, please. And just to drive this home a little bit, I wanted to talk through the antibiotic example kind of in more detail. So how we've thought about this in terms of antibiotics for sepsis is that we want to start from a recommendation with fairly strong evidence.
And so here on the left, we see the revised recommendation in the Surviving Sepsis Campaign 2021 guidelines. Importantly here, this was a change from prior guidelines in that the recommendation is now kind of stratified based on patient severity, kind of what the presentation looks like. So here the goal is that for patients with where sepsis is definite or probable, or shock is present, the recommendation is antibiotics within 1 hour. Otherwise, the recommendation would be within 3 hours if there's some kind of lingering concern for infection. But this doesn't necessarily get us to the point of practices. And so basically what we did was we kind of thought through what are potential practices that might be implementable to help address this. And so won't go into too much detail here, but so in terms of screening, we need a way to identify patients who have infection and sepsis. There needs to be repeat assessment of clinical criteria, kind of once the patient has presented. Potentially most importantly for our purposes here, prescribe antibiotics rapidly for patients with shock or overt organ failure. This is a really kind of tractable practice that we can look at. And then if indicated, we want antibiotics with appropriate coverage. And then it could be possible to defer antibiotics for patients with unclear diagnoses while we complete the assessment. Next slide, please. And just kind of put this all together, this is kind of the way that we've kind of thought through this whole process, which is, so on the left-hand side, we have practice assessment. So the quantitative example, I kind of described it at the beginning, kind of looking at variation. That's kind of an example, but we do need to kind of expand upon some of the qualitative work we've been doing as well. So would want to do interviews and surveys to better understand barriers and facilitators. And specifically relevant to this idea of tailoring antibiotics. So tailoring antibiotics based on patient severity. And so just a few of the possible barriers and facilitators we came up with kind of in early pilot work is a potential lack of feedback, some emergency department specific issues like overcrowding, as well as workforce related issues, or kind of maybe more accurately workflow related issues, and kind of the ways that we can leverage effective nursing resources to improve antibiotic use. And so on the right hand side, this is where we kind of match these ideas with some possible strategies, potentially the most important one being on top, which is thinking through creative ways to deliver feedback in a way that's meaningful to clinicians. Next slide, please. So I want to spend just the last minute or two here, which is on this issue of health equity. So the two papers referenced on the bottom left, so both of these really made a very, very strong case for incorporating health equity into the implementation process. Just kind of the key take-home message here is just that we need to incorporate health equity from the outset and within all implementation activities and phases. I think one of the most important is likely the one at the top of this table on the right, which is engaging interested parties and or stakeholders in this process from the beginning, and making sure we're trying to engage them throughout the process as well. And so in addition, it's important to lay the groundwork early in the process that health equity is important, and we want to actively incorporate this throughout implementation as well. Next slide, please. And so lastly, that idea of kind of incorporating health equity into implementation is fairly big picture. So one example of trying to make this way more understandable and actionable is the health equity implementation framework. So Woodward et al. Presented this a few years ago. And so the idea here is to take an existing framework in implementation science, which helps us understand barriers and facilitators, and to add on domains that are relevant to health equity. And so this is definitely problem or kind of condition specific or kind of project specific, but this is a process we can do that really helps to actively incorporate health equity. And so just kind of a last final point. So really the main idea here with this framework is to try to do two things simultaneously. So to achieve successful implementation, but also to actively work to improve health equity. And kind of to put that part slightly differently, actively work to improve sepsis or health disparities. Next slide, please. So just kind of very quick final conclusions. Like I mentioned, we can kind of reframe the sepsis disparity question potentially in terms of unwanted variation in sepsis risk and outcomes, as well as clinical practice. And we have potentially effective tools to help reduce unwanted variation and improve care for all simultaneously. But it's important to kind of use theory to derive these implementation strategies. And then lastly, like I mentioned, so we want to focus on these two goals at the same time, which is achieving successful implementation of evidence-based practices that will help improve sepsis care, and also ensuring that disparities are successfully addressed as well. Thanks so much. And I guess next slide, please. Thank you so much for your time, and happy to take any questions if there's time available.
Thank you, Dr. Donnelly. Are there any questions for Dr. Donnelly? Well, if there aren't any specific questions, I think this is a perfect segue into our panel discussion, and I would like to turn it over to Dr. Ashana, who will go ahead and moderate that session.
Thanks, Dr. Esper. And we'd invite all 4 speakers to come on video. Thank you all for such wonderful talks. As Dr. Esper mentioned, we have a few questions that we would like to ask. And in the meantime, if folks want to drop additional questions in the chat, please feel free to do so. So the first question is for Drs. Rudd and Martin. Thank you so much for your talks. So I'll give a little bit of background to this in case you're not familiar with the analogy that I'm talking about. So Kamara Jones is a health equity scholar, and she has proposed or described this cliff analogy of levels of health prevention, in which she described people walking towards the edge of a cliff and then falling off to the bottom, where an ambulance is waiting to rescue them. And so the ambulance in this analogy represents tertiary prevention. Secondary prevention would involve installing safety nets to catch people before they fall to the ground. And primary prevention would involve erecting a barrier at the edge of the cliff so they're unable to fall in the first place. And I'll just preface this by saying that this is sort of a provocative question, but so much of what we do seems to be analogous to the ambulance. Both Drs. Rudd and Martin described that patients experience a lifetime of biological and social risk for sepsis. They develop multimorbidity, infection, and perhaps they're unable to manage it because they don't have good outpatient healthcare access in their communities. And then when they become critically ill, we meet them. So the first question for the two of you and for others as well is, what are the advantages to this approach that we take of sort of focusing on sepsis in the ICU? And then what may be disadvantages to this approach, and how might we address those? An easy one to get started.
You want to start, Christina?
Sure. Well, I can think of all sorts of disadvantages, so maybe I'll start there, and then I can think about the advantages as well. For me, it's the combination of the sheer numbers of incident cases of sepsis each year. If globally, if we continue to allow 50 million cases of sepsis, like some of those people aren't going to be picked up by a good ambulance, right? And they're not going to, we can study, till the cows come home, like what to do once people have sepsis, but we're not going to be able to give every single one of those 50 million people the best evidence-based care. And so I think while we do need to continue to improve that kind of tertiary level of like build our evidence base, know what we can do to improve care for people once they already have sepsis, we have got to slow the volume of people that are showing up to the hospital with sepsis. So I think that's one. And then two is, I think it's the right thing to do as healthcare providers to want people to be healthy and not wait until they're sick. And so I think there's all sorts of things that we could be doing for primary and secondary prevention. I'll pause and let others maybe start that piece of the conversation. But I think purely looking at the numbers and just looking at the ethics of it, I think there's a very strong argument for preventing sepsis through all sorts of methods that I and others have kind of already started to bring up today.
Yeah, and I think Christina said it exactly right, and it's certainly ethical, moral, and healthcare correct. It's an imperative. We all recognize the complexity of sepsis, but to me, there's a lot of work to do because we should be preventing it in all of those areas, right? There is primary prevention, and Christina proposed a few areas where you may be able to use technology and other tools to identify higher risk patients and do surveillance and other sort of monitoring things would help them to know when they should be concerned or when they should seek health care. And then there are other aspects too. So conceptually, right, if we think of sepsis as an infection that creates a dysregulated immune response that leads to organ dysfunction, like the prevention of the organ dysfunction may be another one. So in my talk, for instance, I talked about how organ dysfunction may track with comorbidities, how those are related, and how we might be able to help better understand that. But that's both a pathophysiologic component as well as a more clinical component, sort of almost epidemiologic. And then finally, the latter part, we probably find it easiest to implement strategies in the hospital, right? Because patients are there, they've successfully engaged the healthcare system, but we've missed a lot of those earlier opportunities, and that's not correct, and it's certainly not the best way to do it. And I'm not arguing that healthcare is the same, because clearly it's not, right? Hospitals different, providers are different. They're not necessarily, you can't argue that someone presenting to the healthcare system is the solution. So there are still things to be done in that realm as well, right? To better deliver care for people who are critically ill or have sepsis. But I think sometimes we're simplistic and thinking that, that's the place to start because it is probably easier, but it's really missing probably the bigger picture and where we have the better opportunity to prevent sepsis.
And I'm reminded of some of Hallie Prescott's work on, pre-hospital trajectories into sepsis and how we could maybe combine that with community-based participatory research and really think about what are the models that communities themselves need to move that care upstream.
Yeah.
And one thing, sorry, go ahead, Greg.
I was just going to say quickly, and it reminds me of what John Donnelly put in, that there's also the access to care element. So there is, and I know, John, you know this too, many of you do, that in more rural areas, there are challenges, right? So particularly in a timely condition like this, I think people understand stroke, cardiac arrest, maybe MI. They don't necessarily understand sepsis as well. And they don't understand the urgency of seeking care. And for people that are further away from a healthcare system, that becomes a problem for delivering timely care as well. So there's an educational component that needs to happen as well.
And I'll piggyback off that. I think the messaging to the community, there's a lot of potential there. And Christina, you mentioned, we talk about the link between comorbidities and organ dysfunction and outcomes in sepsis, but then there's also this component of, how we treat the morbidity and the control of the comorbidity. And so if there's an opportunity for us to have more data regarding that and messaging the community and patients and providers, then there is a better opportunity to impact prevention.
Yeah, I agree. And I think I would even take that one step forward, even though, I focus primarily in thinking about individual level medical risk factors for sepsis, and particularly certain comorbidities and especially multimorbidity. And Greg did a really nice job taking us through, again, these individual level risks, both biologic and social. I think, we really need to be thinking more about not only individual level medical risks, but those social determinants of health, particularly determinants at the community level and the society level, and kind of the data that Chris was presenting, and thinking about how can we prevent sepsis, not only by finding individual patients at risk and tinkering, with their medications and their medical management to reduce their risk. There's a lot of things that we can be doing at the community levels or even the societal levels to be thinking about how can we prevent sepsis among whole communities of patients who might be at risk. So I'd love to hear, Dr. Chesley or Dr. Donnelly, may have other thoughts there on where should we focus beyond just the individual.
I can jump in. So, I think about this in a few different ways. Certainly, there needs to be more understanding of which structural disadvantage contexts influence things like sepsis risk factors, and probably also things that were sort of mentioned by Drs. Martin and Rudd, which are, capturing those patients that don't have that intersection with the health system appropriately, and that leads to an adverse outcome. So certainly that needs to be an area where we understand more as both the healthcare system, like researchers and healthcare providers. So that's one. But I have thought about, what's analogous in other kind of like fields, and so I really think that the definition of sepsis, especially as it exists now, is very difficult to work with as someone who is trying to think about disease prevention, because when you make a definition that it is predicated on organ dysfunction already happening, it then becomes difficult to think about what the preceding steps are to capture the population that are at highest risk. And that's why I think there is much opportunity in trying to think about structural disadvantage and how those risk factors come together. Because I think that intersection, I alluded this to a response from Dr. Martin's question in the chat, that connection between heightened risk for sepsis and known structural risk factors for sepsis can maybe get to these ideas of biological profiles that then portend these like adverse outcomes that lead to disparities in a way that we're not thinking about currently. And I'll stop with my kind of like soapbox here with saying like a targeted biomarker that would help with identifying this and was also shown to be, population discordant would be very helpful as a first step. And I don't think we're there yet as a field.
Yep, definitely. I think just to echo a little bit of what was mentioned earlier, the communication with the field and with the community has felt like a really big challenge, and kind of understanding, how something like a fairly straightforward infection could end up kind of going towards sepsis. And so it feels like the sepsis awareness organizations and kind of leveraging other aspects to help with the communication piece is an area that I don't personally have experience or expertise in, but it'd be great to kind of learn a little bit more about what's been effective there.
And it looks like we have a question from the audience.
Yeah, may I have a question? So, yeah.
Can you please state your name and
yeah, my name is Zhen Li from Texas A&M University. So, great session and great talks. So my question is, in addition to the living conditions such as poverty, does genetic background, such as certain gene expression levels or differences in the immune cell functions, also contribute to the racial disparities?
I'm happy to take first pass on this question. So it's a good question to be thinking of, especially when we talk about biological determinants for sepsis and disparities. I think that the first place to start is a recognition that there are no genetic epitopes that really separate racial groups from each other in a way that has been validated, consistent, and is population attributable, especially given the amount of genetic admixture that exists between races. And so it becomes difficult to think about how genetic differences could represent a targetable or reliable marker for adverse sepsis outcomes in the context of race. With that said, I think that what we've been, and sort of in the comment that I was like leaving about biological impacts on racial disparities, I think that one thing that we have not done as good a job of as understanding beyond just genetics, biological profiles that could be associated with racial differences, and then how the mutability of those profiles over time contributes to different population risk. But in terms of distinct, identified genetic epitopes that separate, disease outcome differences, between races, it has yet to be studied, because it's, the simple matter being that racial groups are able to have genetic admixture, and that's why genetics becomes less helpful for that difference.
And one thing that I'll add to that, I totally agree with Dr. Chesley, just putting together pieces from Dr. Martin and Dr. Rudd's talks. Dr. Martin, you showed how, that age is such a huge risk factor for sepsis incidence and mortality. And then Dr. Rudd, you were talking about this difference between sort of biological and chronological age with the epigenetic study that you shared, that there's this phrase of racism can get under your skin, poverty gets under your skin. So literally, there's this concept of embodiment, that human beings embody their experiences, meaning that the social conditions that we face can get programmed epigenetically and then change the way that we age. And so I think that may be one potential mechanism that may also explain why Black patients are so much younger on average when they become critically ill. Their chronological age is young, but their biological age may be much greater because of the social disadvantages they have faced.
And I think that's one more element, like Chris was saying, there's the element of biological and structural elements, right? But that's another one deep that I think is really good to better understand the chronological age and both risk and outcome of sepsis. But the only thing that I would add, because I agree with what Chris said really nicely, is that, much of the disparity work that we see in sepsis is really based in the US. And so what Chris said is absolutely right. Like race and genetics do not track in the US. There aren't known polymorphisms or expression differences that we can assign to race. There are gender differences that we see elsewhere in the world, and it may be that there are other disparities, but almost certainly if there is a genetic factor, which people have sometimes pointed to, for instance, disparity of genetic factor that's going to track, and certainly it's outweighed by the other things that we see, which are vastly larger components of disparities.
So I was wondering, what's the current standard of care or diagnostic procedure to identify that the patient is going into sepsis? And is it the biomarker discovery, or is it the immune response of neutrophils? How is it done, and how soon is it done, after which the antimicrobial regimen can be administered, and how effective it is in the current state of the art?
And I'll maybe tackle that first, and I might even think about what John was describing for implementation science, and how do you think about that from a process perspective. I think we all have experience with it. We all realize that there's initiatives in place. I don't think that we're consistent about it. In many ways, I think surveilling for infection may be one of the keys, which is why when Christina was talking about using technologies or other approaches to identify high-risk populations, what you're probably really looking for is infection among people who are at higher risk of developing organ dysfunction and sepsis, because identifying people who have organ dysfunction is far too far down the road in order to have the opportunities for prevention. In my mind, and this sort of gets back to the sepsis definition, which I'll tackle simply because I was one of the co-authors for the definition. We stepped away from a couple of things. One is SIRS, right, which went by the wayside, and I think we do realize that SIRS, as much as it's imperfect, was a surveillance tool that could be used, although largely it was being used to try and identify people who are having that aberrant response. It's still downstream of the infection and potentially downstream of what we might be able to identify people who are at risk of sepsis and organ dysfunction. And the other part is that organ dysfunction component is also imperfect. But I was one of the dissenters in that group that felt like maintaining an element of sort of moving from upstream to further downstream was important, both for epidemiologic and for clinical purposes. But conceptually, I think the concept still works. That the purpose here is to say, if sepsis is defined by organ dysfunction, we need to be upstream of that. Whether you call that infection, which is largely what Sepsis 3 said, is everything upstream of that is infection, that surveillance element still needs to be in place. Whether you're surveilling using biomarkers for an aberrant response to the infection, or are you surveilling for the infection itself, or using other clinical risk factors, I think is still the question. And that's where the implementation science piece comes in. Obviously, I'd love to hear others, right? Because everyone else thinks about this and works on it too.
I guess just super quickly, I fully agree, and I think one challenge kind of with that upstream piece has been kind of working in systems that aren't necessarily fully integrated, and so I think fully integrated kind of, we'll call it kind of pragmatic quality improvement work. I think it could definitely benefit from thinking through how we consider sepsis risk, and kind of whether there's a way to incorporate some more advanced statistical techniques, or at least even like a more simplistic risk score. I think that piece has kind of not been fully developed for totally understandable reasons that would be very difficult to implement.
I have a question here. It's pretty here. I think regarding what Chris was mentioning. So, what I understand is that there is not much strong evidence to support the genetic factors associated with susceptibility to sepsis, especially in African Americans. Do you think it is more to do with there are not strong genomic databases for this population group? Because most of the databases are primarily Caucasians, because there are some studies, maybe Veteran Affairs has or something as I haven't seen much strong genomic studies done in these patients. So do you think that could be a factor because we don't see anything because the databases doesn't exist?
Yeah, I think it's multiple factors, and I think one of them has to do with representation in genetic studies, certainly. And I think also it becomes challenging moving from kind of like a study in a population attributable, like I'm talking on like a national scale, or even like more like a regional scale, ensuring that there's enough like diversity in recruited populations, I think is one thing. But for me, and again, this is someone who's like, I am not a genetics researcher, I'm a health equity researcher. The idea that genetics as sort of like a biological difference between races kind of falls flat on its head when you acknowledge that racial groups are able to procreate and have genetics of any kind of combination. And so it's really a snapshot. Like every genetic study from that perspective then becomes a snapshot in time, and given time, these population differences, there's nothing that would prevent someone who has Black parents and white parents to identify as one or other race. And so some of this is the stuff of the social context and the social definition of race as a social construct rather than a sort of biological construct. And so I think if we think about what's most useful bang for buck with either an intervention or for like the context of designing a study, focusing purely on the genetic piece of sepsis risk factor and racial disparity seems like there's very low pretest probability that would be an efficient use of study time. As a researcher, that's kind of how I think about it. Now, it's possible that there are epitopes that are associated with racial differences and on sort of like smaller kind of timescales, and it should be studied and sort of thought about what it means more generalizable. But if like I don't have it or my grandparents don't have that genetic epitope, they're still at higher risk for sepsis. In fact, like my grandparents have had sepsis and respiratory failure. So it's kind of from a practical perspective and from a research and known sort of like biological construct perspective, it's why it doesn't kind of match together. But happy to hear other people's thoughts.
Yeah, I totally agree with what Dr. Chesley said, and there actually have been, like Sarah Tishkoff at Penn, I think, has done some good genetic studies where she has shown pretty definitively that individuals with African ancestry actually have more genetic diversity among them than an individual. So said another way, a person of European and African ancestry are more genetically similar than two people of African ancestry. And that sort of is logical if you think about where our species originated, right? There has been more time on the African continent for genetic diversity to develop, because that was sort of the origination of the species. So actually, there is more genetic diversity among people who we identify as Black in the United States. And so it would not be possible for there to be a single genetic root cause of this higher incidence of sepsis in that group. I think Dr. Liu is next.
Great, thank you guys so much, and that was really some wonderful talks. What struck me from what you all described together was the challenge of who is speaking on this topic. Like everyone here is or largely pulmonary critical care or does research in the domain of hospital-based or severe infection. But many of the points that were raised really have to do with the precursors, the syndemics, the multimorbidity, the geographic or segregation, or all these other factors. And I wonder if you have thoughts on who we need to bring into this conversation. How do we do so that we can make sure we have really smart and talented and innovative people who actually have the levers and capability to do some of that upstream work and ultimately implementation or intervention.
That's a terrific point, Benny, and thank you for making it. I mean, clearly, and I'll say something that I think everyone will consider to be obvious, but clearly it needs to involve a diverse group of professionals, meaning multi-professional or professional teams, but it also has to engage health systems and communities, because it's all of those pieces together. And if I were to sort of fast forward and say, like, how might you do this? I would think you might start in some integrated health systems like the VA or like Kaiser or some other systems where care is better integrated and data systems are more integrated and patients and encounters are captured. Particularly if it's engaged in a community where there's a better way to roll out and test interventions. But that would be one way to better understand a lot of the factors we're talking about and how to pull them together and what interventions are going to be most effective. But in my mind, there's it's a huge opportunity, right? So you can start in a lot of different places, but I think that maybe that's the easiest place to start, but it does have to pull together all those different stakeholders to make it work.
I will also plug sociologists here because they have a more sort of robust understanding of how to operationalize some of the some discrete kind of structural disadvantage and determinants that I think has not been easily or more widely sort of adapted in many like healthcare situations. And so in a lot of the work that I do, it is trying to learn about how different structural determinants have been operationalized in fields such as education, economics more generally, and trying to think about what we know about other fields and what that means for like building that social context and what that means for a healthcare experience. But like on top of that, I think it's probably the first step is really like engaging community. And so like, especially when you're starting to think about intervention development, I think that the successful studies that have been able to make a difference on a more local level for things like cardiovascular health have all partnered with a captive audience or captive stakeholders that have a direct connection to people that experience these disparities. And so it's kind of might be an easy, not easy, but it would make sense to kind of go back to some of these discussions about awareness, vaccination campaigns, and things like that, and making this connection to sepsis as related to things like your flu vaccine, your pneumonia vaccines, these things that we do for children that should be important for adults, like that kind of a discussion. So there are many opportunities. So the problem is complicated. There are many opportunities to get started literally anywhere. So, but it's a great question.
Thank you.
I will just highlight that I think like Tom Valley at Michigan is a person who does this really well. He focuses on rural critical care disparities, and he works a lot with Mari Huff, who's a social epidemiologist. Dr. Rudd showed work by Nancy Krieger, who's a social epidemiologist. In a different field, she focuses a lot on oncology, but that might be a good model for us. And then, there are divisions that, like, for example, the Hopkins Division of Pulmonary and Critical Care has hired Katie Hauschild, who is a sociologist, into their division. So there are models of ways that this could be successful.
So I think we're nearing our break, but we have maybe time for one more question or comment by Ionis.
Yes, thank you so much for the wonderful talks. I have a comment and a question. We all share the struggle with the sepsis definitions. It's very difficult to do research if you don't have an amazing definition, because that's what you need. And I can tell you for the pediatric sepsis, in the pediatric sepsis world, which is very relevant to my work, we have the Phoenix criteria, but good news is we're working now. There's a group of us working on a definition for emergency settings, which means we're going to try to use earlier data to help, with defining and studying sepsis. But one question that I have, I think it was the first talk about the subtypes and the comorbidities that in different sepsis patients and patient groups. Are there any studies about potentially some of those comorbidities sharing specific pathways or targets? Because if we're trying to tackle, racial disparities, maybe we should look into the comorbidities themselves and see if there are any commonalities there that we could target with treatments.
That's a great question. I think that was one of the studies I shared that had used the MIMIC data set and latent class analysis to identify these different classes of patients admitted to ICUs in the US, and then look to see association of those classes with risk for organ failure and for sepsis and related mortality. I am not aware of studies that have like walked that full chain of from association to causation of first identifying people that cluster based on their baseline risk factors. Particularly, I think you're asking about their medical baseline risk factors, and then looked to see whether there's association in the physiology of those risk factors, and then see if that maps on to subphenotypes of sepsis. Maybe it's not important that they do map on. Maybe it's just enough to know that there's that shared physiology that we might be able to intervene upon. I would defer to some of my colleagues that have more translational expertise that really understand more of the inflammatory pathways, or that are looking at microvascular changes, for example. I think some things have been proposed, but I'm not aware of any really clear, concrete evidence that is showing us shared pathophysiology between these really important conditions that are putting people at risk.
Thank you.
I don't know if anyone else wants to tackle that, but I'll agree completely with what Christina said. And I think, at least simplistically, I don't know that the pathophysiology links chronic comorbidities to acute organ dysfunction, although we do know that those are risk factors, right? So that we know, for instance, that chronic kidney disease is a risk factor for acute kidney injury. Chronic lung disease probably also contributes or leads to more acute respiratory failure, but whether the pathophysiology or the pathways involved are the same biologically, for instance, I don't know that we know.
Well, thank you all for a great discussion. Deep and I would like to thank all the speakers in this first session. I think this this puts an end to session 1, and I would want to turn it over to Nitin, but want to thank all of our speakers for fantastic talks.
Thank you, Annette and Deep, and everybody, all the panelists. It was a great discussion. I hope that everybody had a chance to take away some critical messages from this panel. Let's take a quick break. We were supposed to have the break from 11:45, but it will be for 10 minutes short, but I think it should be enough to grab some coffee or lunch quickly. We will reconvene at a couple of minutes before 12:15 schedule so that we can get it started. At 12:15 will be the sharp time when we will have the first talk started for the second session. Thank you.